Thank you, and thank you, Hunter's Hope, for giving me the opportunity to go over this today. And I always tell people that I'm the Doogie Howser of nursing, because I am obviously too young to have 20 years of experience. Okay. And so we're going to talk about why is transition of care important. And so recently, my daughter and I traveled to Alaska. And so you're going to get to see photos of that. But I thought this picture with kind of the uprooting uh, was a good analogy for what this transition of care can be like for a lot of our patients. And so why is it important? And full disclosure, at MGH, we don't have as a full transition of care program yet. But of course, adults can have different comorbidities, the disease characteristics change, and then you need to be able to provide family counseling for those people that are going to go on and have children. And then there's these big legal questions that come up. So at MGH, at least, the legal questions actually begin at age 13. So at age 13, kids medical records are somewhat protected unless we say that they are medically complex enough that their parents need to have full access. And then depending on your state, when you fully need to transition into an adult care program. So at our center, you stay with us for your neurologic care forever or until Yetta becomes a attending. And your other services do transfer. So your like endocrine, your GI, all of those things do transfer to adult. And then the big problem has been that for many of our patients, I think all of us know that it's been this kind of bridge to nowhere, where the amount of adult leukodystrophy centers is very, very small. And so to give some history, you can see that this has been recognized since the early 90s. And I will say, like, especially since COVID, there's been quite a bit of progress. If you go to like the Got Transitions page, they have an online quiz families can take. There's tons of information for people if they can get directed to the right place. And so I think one of the things that was most surprising to me when I started kind of looking into this is how early it's recommended to start these conversations. And as we go through the slides, you're going to see that I think there's a significant amount of room for improvement. And I think one of the reasons is that in this early kind of age group, we all want to focus a lot on telling kids that they can do anything, normalizing the situation. And sometimes I think what's missed in that is the fact that they need specialized care. So yes, they should not put limits on themselves, but they also need specialized care. So we're very fortunate that Yetta was just officially hired today, I hear, as our third gene therapy fellow, but our first that is an adult neurologist. So this will be great. I don't know how many adult trained leukodystrophy specialists there are, but we will have a very skilled one. And so this is a little outdated, but about half of our clinic is adult patients. And we see about like 150, 160 every 6 months. So, it's like 80-ish adults. I think it's gone up a little this year because we have an actively enrolling trial for females with ALD, and then an actively enrolling trial for adult cerebral ALD. So I think the numbers have shifted a little. And so some unique features about the leukodystrophy patients that can be different from other transition to care programs. So cystic fibrosis has done a lot of work on what transition clinics should look like. Adult congenital heart defects similarly have very established programs now. But I think one of the differences is that our patients, as we have all these great treatments coming out that we heard about this morning, hopefully are going to be, living much longer and with much higher quality. but will still likely have some both cognitive and physical challenges. And then the other thing that is unique about especially the autosomal dominant and X-linked conditions is that a lot of the families we see, all the generations have it. And so that's very difficult. I know with the CSF1R patients, because I can never remember the other initials, that's very challenging for many of our patients because they are getting their diagnosis while they're seeing a parent decline, and there's no one that's in that kind of area to take on all the burden. So I think that is a unique issue to some of those adult onset leukodystrophies. And then in addition, those people, many of them have had children, and knowing that those kids have a 50% chance just becomes a very, very heavy burden. And so this is one of our patients that passed away a number of years ago from cerebral ALD. And so I'm going to just go over ALD as an example. I think ALD, is different in many ways than some of the other leukodystrophies, but particularly with newborn screening, if you're going to be identifying more late onset forms of Krabbe or MLD, I thought there might be some lessons to be learned. So one of the big things is that the change of focus of the care. So in our patients that we see that are children, the vast majority of them, the primary concern is cerebral ALD. And whether or not they have it or not, they're getting screened regularly. They're not going to have any symptoms of AMN really. And so a good chunk of the people, so this AI only means that they only have adrenal insufficiency, no cerebral disease. And our clinic is skewed, right? Because we have many patients that are coming just because they have the cerebral disease already. So in general, having adrenal insufficiency alone would be more common, but our clinic base is skewed. But as they enter adulthood, you can see that much fewer people are asymptomatic, but these really more neuromuscular type symptoms are the more prominent features. And so I think I showed you this last year. This was the data we reviewed last year on the handful of men that we had complete data on that had cerebral ALD. And you can see they did very, very poorly. Now, most of these were not treated because they were very advanced. I think only one was treated. And the big kind of iceberg moment for me was realizing that half of those men had known since childhood that they had ALD, but just had never done MRIs once they were older. And so I think we all have hoped that with newborn screening, we'll see a real closing of these advanced cerebral cases. And this was just alarming to me looking at it in this perspective, that it might not be the only answer for these boys as they age if we don't provide them with the correct education. And so based on that, we started to go through our own MRIs and try to kind of see how good are we doing. So this first one, and this also, I added the younger kids because I thought it might be pertinent with the whole screening discussion yesterday. So in kids, we do really well. I also wanted you to think we do well at something before you see the adult slide. And so really only 3 patients were either not being followed by another center or, had already had cerebral disease. And so then their protocol kind of shifts. So in this young kid age group, we then were able to go ahead and so we have now this system, which I think speaks to the importance of how the LCN is funding care coordinators, because this is really work that is a lot of time. And although some of it can be done by people without medical training, some of it really needs to be done by at least, a mid-level provider. So we made an Excel sheet that has every child's MRI in it with their schedule. So that our coordinators do. And then we started by messaging every child that was behind. And then if they didn't respond to the patient gateway message, we called them. And then if they didn't respond to the call, we called again. And then I can be persistent. So then we sent certified mail and we called their pediatrician. And so having done all of that, we are now down to one patient that I don't know where he is. But otherwise, we were able to get every single one scheduled or find out where they were. And at first I thought people were going to be a little like, why are you stalking us? But families were actually very happy, I think, to hear from us. And some of it was misinformation. So that's why I think the nurse was really important. So Stephanie, who's not here, but is a nurse with our group, one of the patients we had the most trouble getting a hold of. And I was really worried because this kid has adrenal insufficiency. So they are not in that VUS category, was just afraid of the sedation and didn't have a good enough understanding. And so sometimes what happens, I think, is we see them when they're babies and we try to give them information. But then it's a year till their first MRI. And in that time period, he looks fine. He's walking and talking. And so it's easy. So it was really the time for that first scan. Once they got to their first scan, they did excellent. And you can see like on whole, we did really, really well. And then for the 13 to 18-year-olds, which is a smaller group, but we were perfect. We got 100%. It was awesome. And this is Rick, who used to be the one that would enter all of this horrible data. And then they turn 18. And all of a sudden, we were at best, I think, like 30-ish%. So this says that only 40% had poor compliance. But I can tell you this is very biased because there are a lot of men that haven't been seen in clinic. So if we've never seen you and you've never had an MRI, then you're not in this database. And the other thing is that we were a center for Minorex for that first trial for the walking. And having done some of these chart reviews, I can tell you a lot of these men that had their MRIs on time also were getting echoes on the same schedule, which to me means they were in the trial because we would never order an echo otherwise. So this is the area where we just have a ton of room for improvement. And so we have, now that we've accomplished reaching out to all the children's families, where our new goal is to start reaching out to these families or men. It's a much harder issue because if an adult doesn't want care, that's their right. Whereas for a child in that high risk time, it's much easier to be pushy, I think. And we also have more clear treatment for the pediatric form. So this is going to be harder. There are several initiatives going on. So ALD Connect has had an initiative over the last year, you might see, where men have their picture and say why they get their MRIs regularly. The other initiative here, which is one of the reasons we haven't sent out all of our blast messages, is that the Minorex cerebral one will now pay men, I think, $500 to get their MRI. So, I mean, we might as well give them $500 if we can. So our plan is, I think for them, we're just going to do patient gateway message and 2 phone calls. And then, you know, I don't know that we are in a position to do much more reach than that. And so last year, in preparation for today, Ken Diefenbach, who I think I spelled wrong on here, is the brother of that man I showed you that died from cerebral ALD. And so his whole family knew they had cerebral or had ALD. They were treated for Addison's, but his brother never got scanned. And when his brother died, he decided he was going to start doing these trials and he was going to do his MRIs. And one of the things he does is he runs a men's like Facebook group. And so he reached out. And I think we thought a lot of men were going to say it was because of like insurance, it was expensive, but it wasn't really, that wasn't what they were telling us. Most of them were saying, like, I've always had a normal MRI, so why would this be different? Some people thought it was going to be the men that weren't married, but it wasn't, that was also not the case. Some of the men said they thought their wife would notice. So since their wife didn't notice anything was wrong, they didn't need their MRI. And some of them were like, you don't have anything to do. Now, I can also tell you some of the men in that original group were seeing neurologists who told them they didn't need an MRI. So we have one in particular that was followed by a neurologist in Boston, not at MGH, but had been followed for AMN and adrenal insufficiency and had just been told he didn't need MRIs. And so, you know, some of it is educating the larger group. And so then my hope is, and I didn't put this in, but the other thing we've been doing at our center is we've changed how we're doing the MRIs. So it used to be that we wanted every MRI on a specific machine. And so that meant that for an adult, they couldn't have their MRI on the same day that they were seen in clinic because that MRI machine was used for sedation on that day. So we have decided that we didn't want to let, what is it called, perfect be the enemy of good or whatever. So now we just, any MRI machine. So, and then the other thing we've been able to do is if they come and they're from far away and they didn't get an MRI scheduled or whatever before, we offer them a rapid MRI. So at least we get them in a machine. So I hope that in the coming bit, that's going to show on this. And then the other thing we've done is we've started to make sure we're talking to families about this during childhood and also telling moms and dads, because moms all say, well, he's going to get all his MRIs because I'll kill him if he doesn't get them. And the truth is, like, my parents don't know the last time I went to a doctor. You know, eventually you can think that, or they could tell you they did it, right? So we are trying to talk honestly about the fact that this is a problem and that many men that were really compliant all through childhood fall off the wagon. And so I think hopefully by removing some of that idea that, well, my kid's going to do it because most of them say, or I'll kill him. Like that's the most common phrase. But I think that's something we have to work on. The other biggest one here is the gene testing and for the general leukodystrophy clinics. And I think the man from Ionis or Vigil, I mean, is gone, but we recently met with, we had a joint meeting in March yet, or no, last month with the frontal temporal group at MGH. And I can tell you at MGH, they are not testing genetically. And when they do test genetically, they're sending it for a panel that tests for 3 genes. And we have had 2 deaths that were diagnosed on autopsy this year. They were diagnosed on autopsy with having that leukodystrophy. And still, so Yetta and I are going to be attending frontal temporal lobe clinic with the boxes from prevention, which provides free genetic testing. They have not actually invited us, but we are going to be there because this is, I don't understand how you have 2 people in a year die from an autosomal dominant disease that could be treatable for those people's kids, and you still won't test. That's all I had.